I am Sakshi Sushil Sancheti, and today's my topic is antiviral drugs and antiretroviral drugs. So today's agenda of the presentation is HIV treatment principle and guidelines, therapeutic regimen, first line regimen, second line regimen, prophylaxis of HIV infection. HIV treatment principle and guideline. Everyone with HIV infection, regardless of CD4 T cell count, should be offered antiviral medications. HIV therapy is particularly important for the following situations: when the patient is having severe symptoms, presence of opportunistic infections, CD4 T cell count is under 350, HIV related kidney disease is present, or presence of hepatitis B and C. Initiating antiretroviral therapy. WHO and NSCO recommended delaying start of antiretroviral therapy in asymptomatic HIV infected subjects until the CD4 count failed to less than 350 cells or symptoms appeared. Early damage can be minimized and the prognosis improved by prompt institution of ART. Transmission of HIV to uninfected sexual partner is also curtailed by early institution of the ART. WHO further recommended lifelong continuation of ART in all the infected patients regardless of normalization of CD4 count. The therapeutic regimen states that whenever ART is instituted, it should be aggressive with at least 3 anti-HIV drugs. The optimum response to any undetectable level less than 50 copies and restoration of CD4 cell counts to near normal within 6 months. There is a sense of well-being and patient gain weight. Neurological manifestation of AIDS are mitigated and new Kaposis lesions do not appear. Therapy with 3 drugs is considered optimal. Additional 4 drugs afford little or no additional benefit. General points of the regimen. 3 drugs in a regimen should belong to 2 different classes. Single class regimen are inferior. For a treatment naive patient, only PI, that is potassium induced sparing regimens are used. Abacavir and lamivudine. Dolutegravir is highly active regimen used for high HIV RNA load. In patients with metabolic disorders, dolutegravir, raltegravir containing regimen should be preferred over PI regimens. If drug toxicity develops, either the entire regimen should be replaced or the offending drug should be changed. Treatment is lifelong. The PI containing regimens are reserved for the advanced case. Institution of ART in patients with latent or partially treated opportunistic infection may produce IRIS syndrome. Pregnancy in women does not contribute ART. Component in the regimen should not have overlapping toxicities. An ART regimen is considered failed when plasma HIV RNA count is not rendered undetectable within 6-month therapy. Repeated detection of virus in plasma after initial suppression to undetectable level. Clinical deterioration, fall in CD4 cell count, serious opportunities infection while continuing drug therapy. Then first line antiretroviral regimens for adult and adolescents. Preferred regimen: tenofovir, lamivudine or efavirenz is used together. Second is tenofovir, emtricitabine, efavirenz. Alternative regimens are zidovudine, lamivudine, efavirenz, zidovudine, lamivudine, nevirapine, and many others. Then the choice of the second line ART regimens are when the first line regimen is failed, that is zidovudine, lamivudine and nevirapine is failed, then we use tenofovir, abacavir. Then tenofovir, lamivudine, nevirapine is failed, then we use didanosine and abacavir. Then antiretroviral drug combination should be avoided. Zidovudine plus stavudine should be avoided because it causes pharmacodynamic antagonism. Stavudine didanosine causes increased toxicity. Lamivudine didanosine causes clinically not active. Tenofovir didanosine is lower efficacy. Lamivudine, emtricitabine, similar drugs are present. Prophylaxis of HIV. High risk exposure, low risk exposure, no risk exposure. High risk exposure is due to source symptomatic HIV patient. Exposure through large bore, hollow, needle stick, deep punctures, sexual exposure, genital secretions. Low risk exposure is due to mucous membrane, small area of brief contact or superficial scratch. No risk exposure is due to confirmed to be HIV negative, exposure to urine, sweat, saliva, unbroken skin and non-stained bloods. Then drug regimen. tenofovir 300 mg daily plus emtricitabine 200 mg per daily. Key risk group: men who have sex with them, sex workers, injection drug users, transgender peoples. Post-exposure prophylaxis of HIV infections for adult and adolescents. Preferred to an RTI, tenofovir emtricitabine. For children less than 10 years, preferred to an RTI, zidovudine, lamivudine. Then MCQs. Sustiva belongs to which class of medications below? Then which of the following bacterial infection is predominant in chronic HIV infected patients in AIDS? TVKC belongs to which of the drug classes for HIV? Then which of the following drug have shown significant result in reducing the transmission of HIV infection from pregnant mother to a baby? And fifth, a 45-year-old male is diagnosed with AIDS. He was living with HIV for more than 5 years. Which of the following statement is true regarding the diagnosis of the disease? The answer to the following MCQs are given there. Thank you everyone.